Ania Derwi and myself and Akademia Motywacji Edukacji. Thank you for coming, and thank you very much, Babak Najand, whom I'd like to introduce, a wonderful CBT practitioner, a psychiatrist from Iran, practicing all over the world, also in Australia. So I know you're everywhere. You today in Poland, and we are very, very pleased.
Doktora profesora Najanda Najana, який є перським практиком психотерапії, який працює. Ми
coming and offering so much support for us and for our Ukrainian colleagues. So really thank you very much, Babak, for this. I also want to say one more thing, that we Poles are very aware of Iranian attitude towards Polish refugees during the Second World War. In fact, they ended up, lots of them ended up, thousands of them, in fact, ended up in Iran, in Persia at that time. And they were escaping from Russia. So quite incredible journey. And I know that they've been really welcome, incredibly warm and very welcoming when they were in Iran. So at this occasion, may I thank you, because we remember this very, very well, and we know as a nation what it is to be a refugee, political refugee. So thank you very much for supporting us today and digging into CBT practical use of these tools with people who are traumatized, who have all sorts of different problems and disorders. Thank you.
Okay, now, do you hear me?
Now it's okay, thank you.
Okay, good. So I think we come to the point to start my talk. Thank you, Igor, for this incredible opportunity. I think I can talk on behalf of my two nationalities, Australians and Iranians, because I'm a dual citizen, Australian and Iranian. And I can utterly say that there are utmost sympathies from both societies about what has happened to Ukrainians, and the magnitude of this heinous crime to humanity. Now, starting with myself, just quickly, originally I'm from Persia, Iran. I've been a psychiatrist in Iran and then cognitive behavior therapist for 20 years. I started my career in trauma by treating lots of traumatized patients in the war in places around Iran. And as the secretary of the Iranian Psychiatrist Association, it was my duty to set up numerous workshops to educate professionals to how to train cognitive behavior therapy techniques in order to treat trauma-based mental illnesses. Then from about 9 years ago, I continued my career in Australia, and I particularly worked on trauma patients in two different categories. One, veterans, Australian veterans coming back from Afghanistan, Iraq, and East Timor, and two, the victims of domestic violence in Australia. So what I suggested to do with ego was the result of all of these experiences. To my experience, even though it's very important to have theoretical knowledge about trauma, at the end of the day, practitioners would need to use techniques in the field, in the real world. And they need to see how and which type of techniques can be used for specific cases. So I saw the list of the lectures. There are incredible lectures talking about all aspects of trauma. And I thought maybe if I show how to use some of these techniques, it would fill another gap in in addressing this difficult situation in Ukraine and Poland with all of these trauma-based issues. So before starting my role plays, which would be the main body of this session, I just explained some very important issues about how to face trauma patients, even before starting any sort of cognitive behavior therapy, because it's important. It may impact your whole approach to the situation. Oh, and of course, I forgot to remember to mention that I'm a fellow and diplomate of Academy of Cognitive Behavior Therapy, and obviously this this movement started after my friend Professor Bob Leahy drew the attention of all of us to the necessity of such an act. So as a member, I just obeyed the advice of my friend Dr. Leahy, whom I saw first time about 15 years ago in a conference in Italy. And ever since, we've had a great friendship and been in contact with each other over different issues and things. So, first thing, I would like to remind you, my colleagues, is that whoever is a trauma patient is not necessarily ready for counseling for several reasons. One, a patient who is in acute stress disorder, which you know is the preliminary step before PTSD. So before post-traumatic stress disorder, we have a 1 month period of acute stress disorder based on DSM-5. Lots of these patients are in crisis. Or if it's not PTSD, the other branch of trauma-based situation or disorders, they are dissociative disorders. For example, dissociative fugue. In the field, in the war field, or after an outbreak of war, we can see plenty of patients in dissociative situation. For example, dissociative fugue. They can't exactly explain who they are. They can't explain from where they're coming. Or they are completely traumatized and acute stress disorder. If you start talking about the trauma itself, right after such a situation, before a good assessment of the patient's situation, you may end up having a distressed patient who is now suicidal, just because the patient carelessly started to talk about that. So before starting these kind of intervention, it is of utmost importance to make sure that the patient is in a relatively stable situation mentally. The other issue is comorbidities. Lots and lots of traumatized patients, especially when they are going towards the chronic phase of trauma, they have comorbidities. That means other psychiatric issues. For example, mood disorder, especially depression, the most important comorbidity. A high percentage of PTSD patients are depressed. Or bipolar mood disorder, or psychotic disorders. Lots of PTSD patients would have comorbid psychosis, which is undiagnosed and erroneously, wrongly, would be classified as part of PTSD symptoms. So it is very important. And also, and perhaps the most important one, comorbidity, is alcohol and substance use disorder. So lots of these patients would use different sort of substances or alcohol to self-medicate, to treat the symptoms when they are distressed. The importance of these comorbidities: if you start any sort of consultation, treatment, cognitive behavior therapy, whatever, without addressing this situation, you wouldn't make any improvement. You wouldn't change anything because the comorbidity wouldn't let you to do so. One day you do your skillful psychotherapy, the other day your patient is more depressed and suicidal, and you would wonder why? Because your patient is using half a bottle of vodka every day. So whatever you're doing is out of the window. So, dear colleagues, be very mindful of these pitfalls. The other thing that I want to mention before starting role plays is, in specifically traumatized patients, alexithymia is a very important issue. What is it? Alexithymia is a kind of numbness and inability to understand oneself's emotions. For all of the patients, we as professionals in cognitive behavior therapy, we know that it can be quite difficult to help the patients to elicit negative emotions. However, this is precisely very, very difficult in trauma patients, because from a cognitive point of view, trauma would cause the patients to be very in trouble to analyze the magnitude of the data that has entered the patient's brain in a very short span of time. For example, 1 second, the patient is standing somewhere with his or her whole family. The other second, the shrapnels would have killed everybody in the scene. And I've seen plenty of these patients, even military or non-military, and they are totally devastated. They are still struggling to assess what happened in that 1 or 2 seconds. Therefore, one of the reasons that they can move on and they can start the process of their grief is that because they are stopped in the first episode of grief, and that's shock and denial. This stage of shock and denial can continue in trauma patients for years and years if we don't intervene. But at the same time, when you start to do cognitive behavior therapy, as part of that, which I'm sure that the other lecturers have explained in details, one important one would be cognitive processing. We will work on that here with role plays. It is a very difficult task with trauma patients. So you need to be very patient in this one. And hopefully today we work on that with several role plays. That's why in each role play, I would need some of you participants to step forward to represent your cases from the cases that you have seen, trauma patients. Each time I will do a role play with one of you. You would present that patient, you would be that patient, I'll be the therapist, and I'll show the technique, how to use the technique. Then, after doing the technique, I'll ask any of you if you have any questions about the variations of that technique. If anybody else has a different patient, that person would come forward and say, oh, I have this patient with this difference. And this one, how would you do this one instead? In that situation, we would have a very lively interaction, and you would know how to use those techniques in the field. And I think in this way, the lectures from other lecturers would be even more helpful. So you would know how they can be applied in the field. If I'm right, I have another lecture in the next session. So in this lecture, I'm going to do several things. One, exploring this situation with the patient. So first, I do a role play and show how you do the exploring this situation, because it is important to help the patient to re-illustrate that traumatic event. This is the key to eliciting negative or traumatic thoughts and negative emotions. If you don't know how to use that, one, you wouldn't create rapport, that means proper relationship with your patient. Two, you wouldn't be able to help the patient to understand his or her negative thoughts. Therefore, we do this one. Then after that, we'll talk about the other aspects of cognitive pattern of mind. As you know, when something negative happens, based on Beck's theory, we have the next step is having negative automatic thoughts. Then the next step following having those negative thoughts would be having negative emotions. So today we are going to do some role play showing how to elicit negative automatic thoughts and how to find negative emotions. And if we have time at the end, I may need to do some role play about crisis intervention, which is very important. Crisis intervention is not for the treatment of a situation. It's for helping the patient to come out of a crisis, which is in turn very important to make the patient ready to sit and talk with you about the actual problem and doing cognitive therapy in the following sessions. Now, the first step is exploring the situation. From now, the rest of this session today would be by consequent role plays. Now, I want one of the participants to step forward and present a case for a role play, a case, a trauma case, whatever it is. And then we start role play. I'll be the therapist, and that candidate, that colleague, would play the role of that patient based on the knowledge about that patient. And we will talk about how to elicit all of the details of the situation, and then we move forward. Okay? One candidate, please. Don't worry, just a case. You just present the case, and we'll do a nice role play. Any candidates? Okay.
Na ten moment w czacie nie widzę chętnych kandydatów.
I don't see any candidates for now, but if there is no one, I can be your candidate. I can present my case.
Okay. So can we see the candidate? Because it's important to see
Yes, that's
the
me.
candidate. Oh, you're the candidate. Okay, good.
To pani jest
Okay, so from now you start a role play. You talk about the situation and we'll continue. So what was your name again?
Czy mam mówić jako pacjentka, czy póki co?
Do you want me to talk as a patient or as a therapist?
As a patient, please. You're representing your traumatic experience.
Mam na imię Joanna.
My name is Anna. I'm 31 years old.
Hey, Anna, I understand that you had a very bad experience that you want to talk about. Is that correct?
Tak, no.
Yes, you must have noticed when I entered the office
Yeah.
over a year ago, I had an accident. You must have noticed I walk in a weird way.
Okay, so Anna, it is very important to talk about that, the details, and that's how I can help you. I hope talking about that is possible. Do I have the permission to ask you to talk about the details if you feel comfortable to talk about them?
No tak.
Yes,
no.
yes.
Okay.
I promised my husband I would come here and I would tell you the details.
Okay, good. I think that's the wisest decision that you have ever made about the situation. So can you explain what happened exactly that day?
Tak, ponad.
Yes, over a year ago, when we went right after our wedding with my husband likes riding a motorbike, and he tried to convince me to ride with him, to take a ride. I was not convinced, but I would sometimes take a ride on a motorcycle with him. And that day when we went on a trip, well, there was this accident. It was a situation, there was a traffic jam on the motorway, and we were stuck in the traffic jam on this motorcycle. My husband was driving, I was sitting in the back seat on the motorcycle. It was very hot. And in front of us, there were loads of cars, and behind us, there were loads of cars. And we were waiting until the traffic jam just relaxes a bit and is less. And suddenly, I remember I was sitting there on that motorcycle. I looked right and I noticed that there was a car speeding right at us from the right side, right-hand side. There was a car speeding against us and it hit us. And then I only remember that somebody started talking something to me. I was walking on the side lane. It was a medical rescuer, a paramedic, who was standing next to me, and he was asking if I knew where I was, and he was trying to manipulate something with me, to do something. He said, I don't know what happened. I know he said we would get into a helicopter shortly. And I did not know at that time, I did not feel my legs.
Oh.
And I asked him if my legs were there, and I didn't know where my husband was, and he didn't know either.
So the whole situation has been very, very traumatic for you, I believe.
Tak, bo ja cały
Yes,
czas nie
that's correct, because I didn't know what was going on. I didn't know where my husband was. They transported me with a helicopter, and I kept asking everyone around where my husband was, but they didn't know.
Yeah. So the whole situation, as I can understand, is that you had a very sudden car accident when you were riding a motorcycle with your husband. And then right after that, you didn't know where your husband was, and you felt that there was something with your legs, both legs, and the whole situation was very shocking for you. Is that correct?
Tak, tak.
Yes, yes, that's correct. It was all very shocking, but on top of that, that situation was even more shocking after, or was also shocking afterwards, because they transported me to hospital and I was given some medication, and I was in that, while on the motorbike, I was in that suit which you put on when you ride a motorbike.
Yeah. Yeah.
But when I was in the hospital ward, the nurses, the staff, I think they thought I'd actually fallen asleep and that I couldn't hear anything, but I could actually hear them talking, and they were cutting this suit, and they kept saying that I was a lost case, that they kept talking about my leg, and they said they would be able to rescue me. And I was terrified because I knew that they would amputate my leg eventually. And I didn't know where my husband was because they hadn't told me.
Yeah, it's been the most shocking experience. And can I ask which part of the whole situation was more traumatizing, more stressful for you? I know the whole situation was very, very traumatizing, but which part of that was more traumatizing than others?
Ciężko mi to
Well,
ocenić.
it's hard for me to kind of assess this, but I believe that the worst was the moment when I was already at the hospital and I was there in the ward and I was being prepared for the surgery, and I heard the staff talking, and I didn't know whether I would keep my leg, and most of all, I didn't know whether my husband was alive or not.
And can I ask what happened at the end with your legs?
Tak, ostatecznie
Well, they saved my leg, the right leg, which was more injured as a result of the accident, and my left leg had only been lightly fractured. The right leg, they saved it, the one that had been mauled more strongly. And I'm now past 4 further surgeries. It's slightly rigid, my leg, but I can walk. I can walk. So, and I learned that my husband was alive after the first surgery.
Okay.
So after I had been taken back to the ward after the surgery,
Yeah.
it turned out that he had been transported by helicopter to another hospital after the accident. And only after some time did the rescue services actually get us in touch and I could call him.
Yeah. So it happened over 1 year ago, but still it is very, very stressful for you. Talking with that, I understand. Is that correct?
No tak, no prawie nie
Well, yes, I hardly leave my house.
wstydzę się
Oh.
swojej nogi.
I'm ashamed of my leg. I have a lot of scars.
Wydaje mi się, że wszyscy patrzą na to
You know, I feel everybody keeps looking at me when I walk,
i widzą
Yeah.
to.
and they can see it.
No i nie mogę wyjść
Mhm.
na ulicę, bo każdy
And I can't walk out on the street because every car braking, you know, the tires screeching, and you know, the sound of car brakes is simply terrifying for me. So I can't go out on the street.
Mhm, mhm, mhm. So this is when you want to go out and be confronted with cars and traffic. Am I right?
Tak, ale też
Yes, but also, well, my husband is not allowed to talk about his motorbike at all at home. Anything that has to do with riding motorbike really gets me nervous, and I feel safest at home if I don't watch TV, if I don't hear anything about any accidents,
Mhm.
and I also try to avoid using my car only when I really have to. If I have to, you know, go by car somewhere, but I really don't like it because I always have the impression that someone will hit us.
Okay. And due to that incident, have you had nightmares or bad dreams?
koszmary mam niemalże ciągle.
Nightmares, well, I keep having them all the time. My sleep is very bad, and I sometimes have dreams about not having legs and that my husband is not there with me.
And have you noticed any change in your mood during this last 1 year?
No bliscy moi rodzice.
Well, my nearest and dearest, my parents, my husband say that I'm very nervous, that I have become very irritable, that it's hard for them to talk to me about any plans for the future, that I'm short-tempered. We were actually planning to have children before the accident, but I don't want children now.
Okay. Can I ask why?
Bo ja już nie chcę przeżywać żadnego bólu.
Well, I just don't want to go through any more pain.
Oh, okay, I understand. So if this issue of the pain is resolved, you would be keen to have children. Is that correct?
Pewnie tak, chociaż
Well, I
nie
guess so, but I know that
w jakim stanie jest moja noga.
given the state my leg is in, and given that I have to watch it, so as not to gain weight, so as not to put excessive weight on the leg, I would have to really stay in bed a lot during pregnancy, right?
Okay, I understand. It should have been very difficult for you considering all of these aspects. So now, have you happened to have any thoughts about death and dying during this last 1 year?
Nie.
Not really. Perhaps at the start, initially I did, but once I could go to the hospital where my husband was, things got easier for me once I got reunited with my husband, and he is very supportive. He's a big figure of support for me, and I know that. Well, I want to keep living for him.
Well, I can reassure you that I can be a help. With follow-up sessions and with all we are going to do from now, you would be in a better place, and probably you would have some more reasons to leave other than your husband. I'm sure that having your husband is a very formidable asset for you. But don't you think that there are other things to live for as well as your husband?
Szczerze powiedziawszy,
Well, frankly, I don't see any other reasons because, well, I haven't been working since that time. I don't know if I'm even able to go back to work to focus. I've been staying home and going to rehabilitation sessions, and I'm happy when my husband is back home from work.
I understand. Have you happened to use anything like alcohol or anything like that to soothe yourself, to make yourself calmer during this last 1 year for these issues?
nie, raczej unikam alkoholu.
No, not really. I tend to avoid alcohol.
I think that's a wise decision because alcohol can be extremely depressing. It can make you depressed, more depressed. Okay, thank you, Anna. So what I did, I want to explore and put tags on what I did during this interview. This was exploration, but I did several things together in this one. First of all, it was assessment. I checked, first I started with the details of the incident. Then I started to ask questions about trauma itself, and it was extremely helpful. Some of the patients would have difficulty to explain about that. Obviously, in such a situation, you would need to put some more effort to ask questions or having more sessions with the patient to ask the patient to explain all of these issues. Then, after that, I started to ask some more questions about depression, suicidality. In the real actual first session, you would need to ask questions about other things as well. Symptoms for psychosis, symptoms for mania, and panic disorder, everything. But obviously I didn't do that because of lack of time, because we have so many other things to do today. Then I asked about substance and alcohol briefly. In the first actual session, you may need to do some other assessments. For example, medical history, for all of the medical reasons for depression and trauma. For example, endocrinologic issues, for example, thyroid issues or other things, diabetes. You need to ask family history of psychiatric issues, for example, any mood disorders, PTSD, because we know that there are genetic background for all of that. And then if you feel at any point that your patients would have serious issues, suicidal thoughts, or psychotic symptoms, manic symptoms, substance use disorders, any of these, or depression, you would need to refer your patients simultaneously to a psychiatrist to treat those issues. Because as I said at the beginning of this session, if your patient has any of those comorbidities, your psychotherapy per se wouldn't be helpful. You need to address those issues as well. It's very important. Now, I did another thing as well. On top of doing this brief mini assessment, I did some elements of crisis intervention. I need to explain these elements of crisis intervention. First, we need to be good listeners. As you saw, I encouraged Anna to talk about her experience. And I was a good listener. I asked more questions. I encouraged Anna to talk about the details. Second, I empathized with Anna. At times, I showed my empathy to Anna. Like I said, I'm sure it's been very difficult, very shocking. How difficult it was. Tell me about the more shocking aspects. And also some back channeling. Ah, yeah, yes. Oh, these details would show your patient that you are present at the time. She would know that you are walking in her shoes, that the therapist is understanding what she's saying. Now, what I want to ask Anna, did you feel these kind of reactions and also my empathy helpful or not? Anna? Anna, did you hear me? Yeah.
Tak. Czy to pomogło? No myślę, że tak.
Yes, I did. Was it helpful? Yes, well, I think this pause was very important, and this pause to think what was the worst moment, because it was a long situation, long description. So this moment when you asked me to pause and think what was the worst part was helpful.
Good. Yes, because it was important because you had several difficult aspects of that trauma, and I was wondering which one was more traumatizing, and that's because of the next part that I'm going to continue. Very shortly, we would understand why. So, aspects of crisis intervention. First, to be a good listener, as I did. Second, empathy. And then giving a brief description of or a summary of what your patient has said. At one point, I gave the summary. I understand that day this and this happened. You were in a motorbike, this happened, you didn't feel your legs, you had the difficulty in not knowing where your husband was, all of this. And the benefit of that is that you're conveying the message that you are actually listening. You are presenting at the session. And finally, as part of crisis intervention, you may end up giving some pieces of reassuring advice. Anna, you said that the only thing I'm living for is my husband. My reaction was, I politely draw your attention to the other causes of life. I said, well, that's a good thing that you have your husband, but at the same time, I hope with some more treatment, you would have other reasons to live for as well. You gave the feedback that no, that I don't want that, but I didn't insist. It is important. In the first session, you may give some advice to your patient. You may reassure your patient. You may support your patient. But if she insists that she doesn't want to accept them, it's okay. You don't need to push your patients. You just need to put the advice there and help them to choose whether they want to take it or not. There would be lots of times for your patients to trust you and to consider your advice. So far we talked about elaborating the situation, a bit about assessments, and also about principles of crisis intervention, very briefly. Each one of these are a huge amount of information. I'm trying to show them in a brief period of time. Now, we need to move towards the next step, eliciting the negative automatic thoughts and emotions, which is very important. Now I need to ask, do you want us to have 4 or 5 minutes break, or you're keen to continue? Decision is yours. Iga, you're the boss. You order me, I'll follow you.
4-5 minut przerwy poprosimy.
4 or
5
5 minutes break. 5 minutes break. Let's have it, and then we continue. Okay.
Ready?
All right.
Okay, that's fine.
Let's take care of ourselves as well in those difficult moments.
Yeah. Okay.
Okay.
Yeah. 5 minutes. I can continue.
Yes, you can go.
Continue. Okay. And now, so for this next session, based on the same case, we are going to elicit. First of all, I forgot to ask if anybody has any questions about the first part. That's very important before moving to the next part, because that part is very important. So we need to make sure that everybody has asked questions. If anybody has any questions, please, or any different variants of the case. Okay, apparently nobody has any questions. Am I right? Okay, that's fine. So I'll continue. So Anna, we are going to, based on the same case that you explored, we are going to talk about or elicit negative automatic thoughts and negative emotions. What I need to explain is that based on the Beck's cognitive model of human mind, right after the negative incident, what we have is negative automatic thoughts. These are the thoughts that would come to our mind, obviously negatively, in a negative way, and automatically. We don't invite them. They come to our mind. And they shape our speculation. They shape how we appraise the situation, assess the situation. And based on these thoughts, we would find some emotions inside ourselves. Now, based on the Beck's model of cognition, we have three main types of negative emotions: anger, anxiety, sadness. Each and every negative feeling that a person would describe would fall under the umbrella of one of these at least. So when something negative happens to us, we should be able to at least show that we've had one of those three emotions. Often, we would experience two or three of them simultaneously. So in trauma patients, one of the important tasks would be finding negative automatic thoughts and negative emotions. The next important thing, even though right after the incident, the patient would experience negative thoughts, sometimes it is not easy for the patient to recognize negative automatic thoughts at first. She would rather experience or express emotions more readily. But sometimes, in some other times, negative automatic thoughts would be easier for the patient to express. And that's why this part should be very, very tricky for therapists. Therapist is the person who decides where to find which approach to elicit as much as he or she can. So we need some more practice, more than one case. So I may need to ask participants to think of cases, and while I'm continuing this case with Anna, it would be very good if somebody else has a second case for another role play right after this, and probably another one, because the variations are very important, and that would stabilize the meaning inside all of the participants' mind, how to do that, because I'm saying it can be very difficult for therapists to do that at times. Okay, when I'm moving forward, I explained the meaning of these feelings for you, Anna, as you are as patients. So that shows all of the participants how to approach the situation. Now I start. Anna, thank you for coming again in another session. In the previous session, we talked about the unfortunate situation where that car accident happened for you and your husband. Now, we want to talk about some more details of what happened in your mind after that. Sorry. Sorry, I had this. We want to talk about some more details. Are you ready to talk about details?
No, chyba tak, no mąż tutaj nam...
Well, yes, I guess I am. My husband's waiting for me, so maybe I can go out to see him if something bad happens here, if it's too much for me.
Thank you. Yes, yes, I believe that's a good thing. And at any point, if you feel, even you feel that it is better for you to have your husband here, that's also okay. You can ask your husband to come in and be present with your talking. This is completely based on what you think is better for you. Okay, Anna?
Tak, tak.
Yes,
Thank you.
yes.
So you told me that after that incident, during this last 1 year, you've had lots of difficulties, lots of negative thoughts about yourself and the world around. Can you explain some of the thoughts that you've had about yourself?
Tak, no to chyba co...
Yes, something that I usually think of the most is how deformed my leg is,
Mhm.
how many scars I have, and that I will never ever be able to wear shorts or a short skirt in the summer, and that it looks disgusting.
Mhm. So I'm sure all of these have been very disconcerting for you. If I understand that correctly, you're saying that your leg is deformed and the scars are ugly, you said?
No tak, tak, ja mogę tu panu pokazać.
Yes, I can show it to you, but but I just cannot look at it myself. For many months, it was my husband who had to take care of the scars because I could not look at my leg.
And can I ask, what happens if your leg is deformed? What is the worst thing that can happen when your legs are deformed? Can you explain? What's so saddening for you when your leg is deformed?
Nie wiem, no wszystko jest
Well,
smutne.
everything is said about that because almost a year ago, I was right after the wedding. My husband liked the way I look. We had so many plans. I could freely jump, walk, run, and I did not have to think whether I'm going to be able to walk that distance or not. And the worst thing now is that now it seems to me that if I go for a walk, I might not be able to continue walking at some point.
Okay, so one unfortunate consequence is that the extent of your activities is limited now. Is that correct?
Tak, tak. Bo ja muszę...
Yes, because I have to protect this leg. I don't know if it will be fully working at any time. The doctors can't tell me that either.
And you mentioned one thing. You said at the day when you were going to wedding, your husband liked the way you looked. So do you think this deformity in your leg has damaged that look? And that might be one of the reasons that you're sad about the situation?
Mój mąż
Well, my husband says it doesn't matter, but this is the way I feel about it.
Mhm. So you haven't noticed any change in the view of your husband, or you have?
zmiana jest taka, że
Well, the change is that he, keeps looking after me. Earlier there was no need. I was independent, and I worked earlier.
And what is the bad thing about this? About the fact that your husband is looking after you, or he seems himself obliged to do that?
w jego opiece nie ma nic złego.
Well, there's nothing bad about looking after, the fact of looking after me, but I feel weak. I feel that I'm good for nothing, that I'm useless, simply speaking, that I'm of no use. I just stay home and do nothing.
Is that your prediction, that your husband would continue your support, or you have some concerns about your husband not looking after you, or being exhausted about that at some point? I'm just asking. I know that your husband has done so many things to you, but I want to know your concerns.
No ja obawiam się, że
Well, I do worry that if I keep, actually, if I continue like this, well, he didn't marry me to look after me all the time. He married me in order to start a family, to have children together, and to live a happy life, and those were our plans. And now it seems that we might fail to fulfill them.
And then what would be the impact of the whole situation on him, you think?
nie umiem powiedzieć.
Well, I can't really tell. He definitely loves me, but it will change his future, definitely.
Do you think there is a possibility for him to regret this decision of marrying you? Or loving you less than before in future?
Żałował pewnie nie.
Well, not really regretting, I wouldn't say so, but he might be disappointed that, it's unclear whether we'll be able to have children or not, whether I will work and function normally. He is now looking after a disabled person, basically.
So, as you saw, Anna, you had some thoughts about lack of something and loss of something, which was limitations that you had, which was feeling weak, which was feeling useless. These are the thoughts falling into category of your sadness. So sadness pretty much means lack of something or loss of something. Are there other things that you have lost due to this incident, you think?
No ja wszystko straciłam, wie pani, no ja jestem
Well, I lost everything. I am a lawyer by occupation, and before the accident, I used to work at a law firm, but for a year now, I haven't had any contact with my clients. I'm constantly on leave of absence from work, on sick leave, and I can't even, imagine returning as a lawyer and as a barrister, going to court. It's unimaginable for me.
That's another saddening thing about that. You've lost your career as a lawyer. Is there anything else you think you've lost due to this problem? other than feeling weak, feeling useless?
Well, maybe it's important to mention that I get angry sometimes. I get irritated, and my parents want to help me constantly, and I'm fed up with it. I'm even angry at my husband. I know he means well, but I simply can't stand the fact that everybody has to keep helping me.
Okay. So you're saying that sometimes you criticize your husband for this constant offer to help you. Am I right?
Yes, I get angry at him. He doesn't seem to see that I can do something on my own, and he keeps trying to help me. I cry, and I feel useless again when I get angry like that.
So you are saying that sometimes you criticize your husband because you think with his constant support, he undermines the remaining of your capabilities. Is that what you're saying?
Well, yes. My husband and my parents treat me like a child now. I know that they mean well, but sometimes it doesn't help at all.
And you said sometimes you were mad at yourself as well. For what reason do you criticize yourself?
Well, I know I should actually sort things out by now and move on. My husband kind of keeps working and actually attends rehabilitation sessions, but he's much more advanced, and I keep focusing on my leg, and I'm ashamed of actually going out so that people could see me. And I'm totally helpless in all this.
So you are mad at yourself because of your disability? Or because you're so focused on your leg? Which one?
Yes, I keep focusing on this leg, but I know that I should actually start thinking about coming back to work, because I can read, after all. I can, browse case files, and maybe I could start, helping back at the law firm again. But I don't know if I'll be able to cope.
It is very important. So you are saying that at the same time, when you have all of these angers and sadnesses towards other things, you are mad at yourself, you're frustrated at yourself because you think you're focused on your leg too much. Is that correct?
Well, yes, because my husband also had a health problem. His pelvis was also fractured, but he doesn't, turn into a problem.
Okay, so that's your anger towards yourself and towards your husband and parents. Is there anybody else you are mad at?
The whole world, really, I believe.
For what reason?
Well, just at fate, really. I'm angry. I'm mad that this happened to us.
And I'm asking this because it helps me to understand you better. Are you religious, Anna? because of this faith issue?
Well, yes, there's also a court case going on. There are
Mhm.
proceedings. I haven't mentioned that earlier, but the guy who hit us with his car was drunk.
Mhm.
I know I'll probably have to testify. I haven't actually done it ever, but I'm mad that at that guy, because he simply ruined our lives.
Mhm. Okay. Okay. And you said you had religious belief. Is that correct? Or you don't?
Well, I don't know if I have religious beliefs. I don't know if I believe in God. We married at church, but I don't think that God should have allowed what happened.
Okay. So while you're saying that you're not sure about the existence of God, you're mad at God because you think God shouldn't have permitted that thing to happen. Is that what you're saying?
Yes.
So that means you have a bit of indecisiveness about whether the God exists about all of this, or it doesn't. Is that correct?
Well, the God I trusted and the God I believed in was supposed to protect, right?
So is that correct, that you think the God that you trusted betrayed you somehow? Is that what you're saying?
Yes, that's correct.
And I believe that's very important for a person who believed in God.
Yes, definitely. My husband is not a believer, but he did agree to our marriage at church, to a religious marriage, and I feel he was right,
Mhm, mhm, mhm. But obviously, as I can see, you haven't decided about this matter, whether the God that you believe was a trustable person or not. Is that correct?
Well, that's correct. I keep thinking about it. I haven't decided yet.
Thank you for being so open and honest with me. And now we talked about your sadnesses and we talked about your anger. Regarding your anxiety, you mentioned one part of your anxiety. You are concerned whether your husband would be happy for the continue of this life as your husband, or at some point he would be disappointed. Are there other anxieties that you might have? Any what ifs? When we have anxiety, we have what if. Like, what if my husband is disappointed with me? So there are other what ifs or not?
Yes, I know that to my husband and to me, that at that moment back then, it was the most important to have children. And now I'm worried. What if I tell them that I can't imagine to be pregnant and have children at this point?
Mhm.
because one is the pain I will have to endure once again. And the
Mhm.
second thing is that I'm not sure whether I'll be able to take care of a child having this leg.
Okay. So there are two what ifs here. What if I can't get pregnant? What if I can take care of my child? Is that correct?
Well, I know that biologically I can get pregnant. Doctors told me that it's possible. There's nothing that I cannot get pregnant, nothing to prevent me from it biologically. But I know that pregnancy is not only a pleasant state, but it involves a lot of pain, especially the delivery is painful.
Yes, yes. So at the end of the day, the process of pregnancy and getting pregnant and conceiving is scary for you. That's one worry, one concern. And then, even if I have a baby, looking after the baby with all of the problems that I have, what if I can't do that? So these are two concerns that you have about pregnancy. Is that correct?
Yes. And well, I don't talk about it with the husband about it because I'm afraid of what he might say. I'm
Mhm.
afraid, I'm worried that he might try to convince me to change my mind.
Okay. And what happens if he tries to convince you?
I don't know. For now, I'm definitely not ready to get pregnant. He will probably have to find some other woman to for living, to sort his life out with somebody else.
And what would be your feeling about that thing if it happens?
Well, if that happens, then I think my life would be over.
Therefore, there are two concerns here. One, you're saying that there is a possibility that your husband wants to convince you about getting pregnant. That's one concern about that. And the second concern is, what if my husband decides to live with another woman? These are two major concerns about your husband. Is that correct?
Yes, that's correct.
I can understand the second one. And the first one, what if he tries to convince me? What happens if he tries to convince you? What's the scary thing about that? What would happen?
Well, the scary thing is that he won't understand how I really feel.
So this discord and misunderstanding between you two, if he tries to convince you. Stand, okay. And I'm sure that you're under so many pressures because of these things. But also, when you were talking in the previous session, when you were talking about people out there, when you go out with all of your deformities, don't you have any concerns about what people think about you when you go out with your deformities? Anything that you may think they think about you?
Yes, my thoughts are that people notice my deformities, that everybody sees it when I walk along a street, when that, simply speaking, you can tell that I'm a disabled person by just looking at me.
So what would happen in their minds if they see your deformity?
Well, I had several situations when people asked me if I needed help, or if there was something I was in need of. I didn't think I was weak, and they see I'm weak.
So you're saying if people want to help me due to my deformity, they would cause me to feel weakness. Is that correct?
Yes, because before that I was an independent person, a fit person. And now when somebody looks at me like that, I just can't bear it.
Mm.
I don't want to be weak.
It's completely a legitimate concept. Thank you, Anna. So we did the role play. Now, how many negative automatic thoughts do you think I extracted from you when you, and for one thing, you did a great job here by this role play, playing that job. Thank you very much. So how many negative automatic thoughts do you think I extracted from the patients that you played the role? Can you make a guess?
Well, I did not count, so it's difficult for me to guess the number, but I think the most important ones that I have in my work with this patient. So you elicited those, definitely the most important ones.
Yeah, I elicited 14 negative automatic thoughts from your patient. I just briefly explained them, but I need to explain what I did. As I said, we have 3 important negative emotions: anger, anxiety, and sadness. Based on the Beck's concept about negative view of a patient, I try to use the dimension of patient's negative view to herself, to the world around, and to future. And from there, I explain to the patient the concept of 3 different types of negative automatic thoughts. The thoughts that were linked to sadness, they were related to lack of something and loss of something. Obviously, lack of something is when you've had something and you lost it sometimes in the past. But lack of something is something that you haven't had forever, but for some reason you realize that you didn't have it. And then you get sad. Either of them can cause sadness. And from there, I elicited a few thoughts related to sadness. I have some limitations that I didn't have in the past. Oh, sorry, 15 negative automatic thoughts. I am ugly because of the deformities. I am weak, and then I am useless. And then I have lost my career as a lawyer. So 5 of them. Then I started to talk about anxieties. And you mentioned one anxious thing. What if my husband gets disappointed? Then you started to talk about your angers. I didn't want to stop you there. As you saw, I said, okay, let's talk about your anger. So important thing is to make the session very smooth. I'm talking about that with all my colleagues. If you want the session to be smooth, where it is indicated, you can let the patient to lead the way. As long as you're going through the agenda, it is important. So it is not a good practice to say, hey, look, we were talking about anxiety, so go back to anxiety, don't talk about your anger. So she wants to talk about anger, let's do it. So I explained, okay, anger is criticizing somebody. Then we started to talk about criticism. And here, she criticized her husband. She criticized her parents, and we needed to separate these two because the dynamic with husbands and with parents are different from each other, even though for both the subject was they treat me like a child. But I'm sure that my colleagues would agree that the dynamic is different. For example, when we are talking about the relationship between the patient and her parents, it goes back to some earlier schemas of early childhood. So elaborating that in the sessions far ahead from now would be important, but different from husband. And then a very incredible and important thing happened. She said, I am mad at myself. Why? Because I have focused so much on my leg. Actually, I can have a job. So somehow she is partially insightful, partially self-aware that she has a childish narcissism about seeing herself the center of everything. So my husband, if my husband pays too much attention to me, he is acting like or treating me like a child. If he doesn't pay attention to me, that means he is thinking about leaving me probably. So that's how she is putting the husband in a very difficult situation. And that can happen with the parents as well. So that's this negative automatic thought, apart from having another one, opens a window to the therapist. Okay, we are dealing with something more in depth than just anger or sadness. It's about some of the narcissistic patterns of her behavior or her traits. And the good thing is she is partially aware of this difficulty. Then I started to ask about other aspects. She talked about, obviously, the driver who were culpable for the incident. And then one of the most important things in this session happened. She expressed her anger of God. At first, she said, no, I don't believe in God. Then she said, yes, if he knew what he was doing, he wouldn't have done that. That means he had a confusion about God. Obviously, if you don't believe in God, you wouldn't have to be concerned about what God did in this or that situation, because you're saying that God doesn't exist. So this is not a concern. But then right after that, when you express your disappointment of what God did, that means there is some religious belief in the background. And then later, when I noticed this problem. Then I pointed my finger on that. And Anna, you explained the delicacy of the situation very properly. That means you know your patient very good. The confusion of the patient. The husband is not religious. And she was or has been religious. But after all of this, there is a big question mark on this situation. And that was why I confirmed this concept with her. Are you disappointed that the God didn't do what he meant to do? And she said yes. And that's another stressor. What we call this is existential conflict or dilemma. So she has a very big conflict about the existential aspects of life. What's God? What does God want about this? If God is recognizing justice, what was the reason God did this to me? And all sort of things. That opens another trajectory for future sessions. So as you can see, eliciting negative automatic thoughts are very important. Then I came back to anxiety and I said, okay, there are some anxieties. What do you think about anxieties? Okay, and that was when something even more important happened. The dilemma of husband. She said, what if my husband wants to convince me? In such a situation, especially about negative automatic thoughts, there is a very important technique that we can use. And that's downward arrow technique. That means, okay, what does it mean to you? What's the worst thing about it? What's the bottom line? So it is not enough that we know that she is concerned about this possibility, that what if my husband comes forward and wants to convince me? Okay, so what? We need to know the reason that she is so concerned about this possibility. What if he wants to convince me? And we know that the problem would be it may create a conflict. And that's, he said, what happened? He said, if he wants to convince me, I may disappoint him. I may be distressed by this. And then there was another thing. What if he leaves me for another woman? Then my life is over. It is another red flag here. An interesting thing is the contradiction between this part and another part. Obviously, I didn't talk about this contradiction because I'm not sure that the patient can tolerate bringing up the contradiction. At first, she expressed her 100% certainty about the husband's support. But this concern shows that she is not that certain. It seems that the husband wants a child madly, And this is her prediction. Whether it's correct or not, we don't know. But if my husband wants a baby, he may leave me for another woman. And then again, I used a downward arrow. Okay, what does it mean to you? And she said, my life is over. Red flag. That means if that at some point, something like that happens, no matter what we've done for this patient, the patient may commit suicide easily. And because so far, we know that the patient has some narcissistic traits in the background, sometimes these narcissistic damages can cause a very decisive suicidal action. So a narcissist personality trait, I mean, not disorder, trait, wouldn't be so lenient towards herself. If she wants to kill herself, she would do that perfectly. So while you're doing just eliciting negative automatic thoughts, you're completing your understanding about the patient. You're finding the red flags in this patient's profile. And then other things. What if I can't get pregnant? At first, she said, what if I can't get pregnant? Then she said, oh, biologically, I can get pregnant. So what's the problem? I'm concerned about pain. So she has another dilemma. So she doesn't want to have pain, but at the same time, she thinks pregnancy would be helpful. That's another confusion in her mind. A pregnancy would save my marriage, but at the same time, I don't like pain. Then another concern, even if I have a child, I can't look after my child. This is another negative automatic thought. So we have 15 negative automatic thoughts, a range of very ordinary negative automatic thoughts to very substantial and sophisticated ones, like the one about God. And I can reassure all of my colleagues that you wouldn't be able to fix things about this patient unless you address each and every one of these ones. Because amongst them, there are things that can be very dangerous. Even the one about God. This patient is highly educated, a lawyer. A highly educated person is very predisposed for existential depression. That's the depression in the patients who are disappointed by life and by their belief system. If they think that their belief system doesn't work, they can fail totally, they can collapse. And that's why this confusion about God can be very important and can predispose the patients to depression. Now, to be precise, in eliciting negative automatic thoughts, we consider 3 types of negative emotions which are related to negative automatic thoughts: anger, anxiety, and sadness. Anger, negative automatic thoughts are related to criticizing others or oneself for whatever reason that they think, we think others have damaged us, or it would be us damaging ourselves. For example, this patient thinks that she is focused too much on her leg, and she thinks that maybe there are other things in the world that would worth to pay attention. Anxiety. being concerned about something that happens in future, having what ifs, and sadness, feeling of lack of something or loss of something. And the more artful you extract the negative automatic thoughts, the better you'll be able to challenge them. Now you can see that if you don't know all of the negative automatic thoughts, it seems that you're walking in a blind room, in a dark room, in a blind situation. In that situation, any therapeutic intervention would be just shadow boxing. You're treating something that you don't know even it exists. You need to know your exact points. Now you know your patients. I'm not talking about you, and obviously you know your patients perfectly. I'm talking about a general concept and all of the colleagues. So I think we only have some time for some questions. If there's any question, please. I tried my best to go through my agenda based on a very short period of time that we had available. Any questions from anybody, please? No questions?
Okay, I would like to kind of supplement this. Oh, there is a question in the chat. What about negative thoughts concerning PTSD symptoms? Am I going crazy? This kind of negative thought. Yes, exactly. Now the question is being read out. What about negative thoughts related to PTSD symptoms, such as, am I going crazy?
Okay. Yeah. So usually people with PTSD wouldn't have this concern. Usually this comes from issues like panic disorder or dissociative disorders. For example, derealization, depersonalization, these kind of experiences. For example, patient feels that he or she is out of her body. That's depersonalization. Or derealization, when following the trauma, the patient feels that everything around her is unreal, not real. And also panic attacks, frequent episodes that may cause the patient to feel that maybe I lose my control, or maybe I die, or maybe I get mad or crazy. Yes, we have this possibility. This is another negative automatic thoughts with the content of anxiety. Like others, we write down all of that. But just one thing that is important. Please don't be in a rush to advise the patients that these are not correct. Because it is very important to make a good rapport, good therapeutic relationship with your patients. If you are in a rush to fix everything in the same session that the patient is talking with you and giving advice, most of the times you would get things difficult. But with regards to crazy, if the patient says, what if I get crazy? this is something that you might need to answer quickly. In such a situation, you can just simply explain that there are no pieces of evidence showing that this sort of symptoms can cause a person to get crazy. This is only related to this specific diagnosis, whatever it is, panic attack or dissociative disorder or whatever, simple anxiety. You just explain the pieces of evidence. And if the patient is very concerned about the symptoms, that's where the patient needs to be introduced to a psychiatrist and take medication. Because when the patients are very distressed, they think they are going to get crazy. If you don't do anything for the patient, if a psychiatrist wouldn't prescribe medications, the patients, because of the severity of the distress, the patient wouldn't continue psychotherapy. So you may simply lose your patients. The patient would be dropped easily because the best type of psychotherapy would need at least 6-7 sessions to start to kick in, to start its effects. If your patient is so severely distressed that he or she says, I'm getting crazy, that means the patient needs medication for some urgent improvements. In other words, even though for PTSD, CBT is the first line of treatment in all of the textbooks, sometimes urgent medication or medical intervention would be needed to guarantee the patient's attendance in the CBT course.
There is one more important question on the chart, if we may. In what direction, where should we refer the patient when the patient speaks about injustice of fate, existential injustice after a crisis they've survived?
Referring the patient?
Yes, where to refer the patient if the patient says of existential injustice after a crisis they've survived?
Okay. All in all, if this kind of issue hasn't induced suicidal thoughts, it's not an urgent issue. You can put aside this with an agreement with the patient. You can put aside this until later, when you address more urgent issues and come back there for therapy. If you are just a volunteer supporter, you need to help the patient to talk about these things, to ventilate herself, to talk about that and feel more comfortable. And then after that, you can refer the patient for some more in-depth therapy to a professional cognitive therapist, because it is a professional type of intervention about existential thoughts about death, justice, God, these kind of things. Having said that, if your patient is religious, sometimes you can use the help of based on the religion, a priest, a rabbi, or whatever is related to that, or kakam, or based on the type of the religion, referring to a religious authority and asking the patient to talk about that person sometimes would be helpful as an additional part or annexed part of the therapy. So even though you're doing your job, your patient can find some peace by talking with a religious authority. Okay, any more questions? Okay, it seems that
I think that with time, the more we get involved in these, we get more and more questions. But I understand that we're going to have another meeting with you, Babak. There's
yes,
going to be a continuation where we speak more specifically about PTSD treatment and all the issues related to trauma. We will talk about thoughts, about feelings, and we'll take a closer look at that with you once again, right?
Yes. May I ask all of the potential participants of the next session to, if possible, bring some specific cases of trauma, specifically related to the current war in Ukraine and all of the refugees in Poland, bringing the trauma cases of this crisis, and we can work on them, because what I'm doing is a practical type of workshop. So I need examples. I can make plenty of examples by myself, but I can't play the role of therapist and the patient simultaneously. I need some vivid cases of the current war, which would show, and it is important because it would show the ugly face of what some of the people have done to people in Ukraine. With these examples, we can show the impact of war, and we can show how to intervene with that in a live and interactive way by addressing those thoughts related to the war scenes and how to challenge the negative automatic thoughts. In the next session, we'll talk about how to elicit cognitive distortions from negative automatic thoughts, and how to, if we have time, hopefully, how to examine negative automatic thoughts with evidence technique, most probably.
Okay, so we meet with you on the 21st of May once again. It's going to be continuation of today's workshop. Thank you for the opportunity to be able to focus on the war trauma and the examples that people will bring to the meeting. So thank you very much, Babak. It's very important that we do not ignore in our work all the contents that people bring to us, because it can emphasize the trauma. We need to notice all those details and address them. So thank you very much for today's meeting. I would like to say that you will have the certificates sent to you shortly. I'm sure we will stay in touch with you after the workshop, and feel free to join us for our consecutive meetings and workshops, and to the next meeting with our fantastic guest, Babak Najand. Thank you very much once again. Thank you for your work, and thank you for your contribution.
My
See you
pleasure.
soon.
See you soon. See you, everybody. Thank you. Bye. Thank you.
Thank you. Bye. We want to thank all the interpreters and Anna for her contribution. Everybody, thank you very much. It's a lot of great work that has been done today. I think Anya was playing herself because it was so authentic and so realistic. The husband, the worry and everything.
I agree.